1 second.
I don't think we can hear it, Maria.
आपको शेयर साउंड भी करना है जब आप पीपीटी शेयर करेंगे।
पता है शेयर साउंड नहीं हो पाया। आरती वाज जस्ट ट्राइंग फर्स्ट टाइम। गिव मी अ सेकंड। ना
हाँ
Yes, yes.
क्या इसमें है ना, इसमें से कर दो। बहुत कंफ्यूजन हो गया आज। 1 सेकंड 1 सेकंड। हेलो एक सेकंड ना, इधर क्लिक करो, इधर क्लिक करो।
ओम सरस्वती नमो नमः। माँ सरस्वती नमो
हो गया।
Please play it again.
नमः। विद्यादायिनि नमो नमः। हंसवाहिनी नमो नमः। ओम सरस्वती नमो नमः। माँ सरस्वती नमो नमः। विद्यादायिनि नमो नमः। हंसवाहिनी नमो नमः। ओम सरस्वती नमो नमः। माँ सरस्वती नमो नमः। विद्यादायिनि नमो नमः।
Can I please have next slide, please? So I now call upon our EIC, Dr. Madhuri Patel, Madam. Madam obviously needs no introduction. She is the Secretary General FOGSI. She is Editor-in-Chief of Journal of Obstetrics and Gynecology of India. Welcome, ma'am. I would request ma'am to now give the welcome address.
Thank you, Pragna, for your nice word. Respected our President, Dr. Jaideep Chand, our guest of honor, Madam Kamal Bakshi and Dr. R.P. Sunawala, who agreed to agreed for this invitation. And I'm very, very happy to see Madam Kamal Bakshi, and Dr. R.P. Sunawala is there. I can't see him, but I'm really happy
Madam,
to
he's
see him.
joining. We've all spoken to him. I think
Yes.
he's just trying to join.
Okay, so I am so happy that they accepted the invitation, and they are real clinician and the academician, and they are definitely going to give us a inputs regarding this, our clinical pulse of Jogi. And of course, today we have our chairperson, Dr. Faisal Louis, Dr. Vidya Thobi, and Dr. Sumitra Yadav. They are not only my great friends, but they are great academicians. And I thought they will also give a very good inputs as far as our papers are concerned. And I must thank Madam Sir VP Piley, whose paper is award-winning paper, and we will hear Sir talking about his paper. It is an original paper first so in India, and he'll be talking how he got the idea, what happened, and the paper really is award-winning, which shows that we can really reduce the decision delivery time and can be beneficial to mother and the baby. Second paper, Atulya is going to talk, are we justifying in doing induction or labor in low-risk pregnancy, primary gravida, at 39 weeks of pregnancy. So her paper is also award-winning, and we will also have our own experience with this paper, whether we should induce 29 weeks primary gravida, low risk, whether we should induce at 39 weeks or we should wait for 41 weeks to induce her. Now, we also have our editorial board, that is Dr. Sujata Dalvi, Dr. Arun Nayak, Dr. Ashwini Balera, Dr. Anayata Chavan, Dr. Our Pragna Changale. Today she's also MOC. And of course, my managerial team, that is Dr. Pragna Supe and Sunit Ambewakar. They all are doing excellent work. And because of them, today I can give my inputs and output both as an editor-in-chief. And similarly, we have our national corresponding editor. They are doing the great work. They are really working hard. That is Dr. Krishnendu Gupta, Dr. Lakshmi Shakande, Dr. Sushil Chawla, Dr. Radhika, Dr. Kiran Mai, Dr. Shobha Gudi, Dr. Deepika, Dipti Gupta, Dr. Mala Srivastav, Dr. Alka Pandey, Dr. Madhva Prasad, Dr. Krishna Kumari, Dr. Sampat Kumari, Dr. Ashok Kumar, Dr. Ramni Devi, Dr. Shobha, Sushil Chawla, Dr. Nidhi Gupta, and all my reviewers. Because of them, because ours is a peer review journal, and because of them, we are really doing a prompt decision making to publish in our journal as well as we are also rejecting them. So many people are very unhappy. And my dear friends, very good evening to all of you. It is with a great pleasure and anticipation. I welcome all of you for this 10th episode of Clinical Pulse of Yogi. Here, madam and sir, we are giving chance to the organizer and the we are giving chance to the authors who are award-winning papers in our Yogi journal, and we are giving them chance. The reason is that they have published a paper. It is a wide, people are reading them, but at the same time, when they are presenting their paper, very few of them are there to listen to them. So this is the 10th episode, and for 9 episodes, we have a very interactive session. And interactive session means how they started this study, what prompted them to do the study, and how they continued, and how they come out with the conclusion. So this is the most interactive session, and this is a unique, clinical pulse of webinar, which we are giving a chance authors and all these stalwarts in the field. They are giving their opinion and opinion. So that is a very this has become a hit program webinar of our journal. And with this, I would like to welcome all of you once again, and I will like one of our master of ceremony to take over the program. Thank you very much.
Thank you so much, madam.
Okay, sir.
So I would now like to introduce our chief guests for today. Next slide, please. So our first chief guest is Dr. Jaideep Tang, sir. Sir obviously again needs no introduction. Sir is the president FOGSI 2024-25, chair of IGA committee of FOG, project lead of USAID projects 2020-24. Was the Secretary General of FOGSI from 2018 to 21. Has been awarded the FRCOG honoris by the Royal College of Obstetricians and Gynecologists, and also he is past president of Mumbai Obstetrics and Gynecological Society. Next, please. Our next guest of honor today is Dr. Professor Kamal Bakshi. Madam is former professor and head of department Obs and Gynec at AIIMS, New Delhi. Senior consultant at Indraprastha Apollo Hospital and Fortis LAFM, New Delhi. Professor Emeritus, National Academy of Medical Sciences. Founder fellow of ICOG, past president FOGSI. First, and she has a lot of awards and recognitions to her name, such as Dr. B.C. Roy Award of Eminent Medical Teacher and the Bharat Jyoti Award. We are honored to have you here with us today, ma'am. Our next guest of honor is Dr. Rustam Firoz Sunawala. Sir is, I think, trying to join. Before that, if I could request Dr. Kamal Bakshi, ma'am, to say a few words.
Good afternoon, everybody, and namaskar to each one of you. I am really excited and thrilled, especially I thank Dr. Madhuri Patel because the Journal of Obs and Gynae has reached great heights, It is one of the oldest journals. And at the same time, I would say As far as the journal is concerned, no wonder Dr. Bharti and all the people, you get the rich science, by all the authors that work across our country. The quality of the journal is again very, very nice. At the same time, I would say that we have a very young and a dynamic president, Dr. Jaideep Tank. He is a great visionary, and I met him recently in Noida, and his project, Adhuna, which is so unique that the title itself, and they have launched in Noida, they have launched in Agra, and many other places. And this initiative of Adhuna, as the name itself, is concerned, is very good, And with this Adhuna project, they are able to take the maternal and the neonatal height to much greater heights, Now coming to as far as the title is such a wonderful title, Clinical Pearls, I would say the clinical pearls of the wisdom. And the wisdom is really excellent. The way you have chosen the topics, wow. And I would say that the persons who are the award winning, especially Dr. V.P. Pally, when I see him, I feel as if I have reached Madras and met Dr. Pally. He's a great surgeon and a great person. Look at the way that this his recent article that it is there. Each one of you, when you hear that, even as far as America and USA is, UK is concerned, their standard time, as far as the cesarean section and other is concerned, they have said 30 minutes, And as far as Dr. Pally is concerned, look at his time limit, 15 minutes, and the way that the crash cesarean, the word he has chosen, the time that has been taken, the team that is done, and as far as not only the work, the reviewing that work, auditing that work, wow, I think he's one of the rare persons who can be, as far as the India is concerned, we are very proud of him. He has invented so many instruments which has saved thousands of mothers and prevented the children from becoming orphans. To my excellent colleague, Dr. Rustam Sonawala, where I met him at Kanpur when he was made the president of the FOGSI, a Federation of Obstetrics and Gynecology. Again, he is a great surgeon and very well traveled, and he's known nationally and internationally, and he has many innovations. And as far as our young persons are concerned, I would say each one of them have been so nice. The special namaskar to Dr. FOGSI, Dr. Vidya, Dr. Sumitra, and our young, the moderators, Dr. Pratnya Supa, and who has made this day possible. I'm looking forward to become more wiser by listening to Dr. V.P. Pele and as well as to our other speaker, Dr. Shana. Thank you for your kind invitation.
Madam, thank you very much for your words of wisdom, madam. And I'm so happy and excited to be here, being here. And madam, let me tell you, our journal gets more than 1100 papers, and we have to only select 110. So our editorial team, the national editors, and the review teams are doing great work, because out of 1100 and 1200, if we have to select only 110, that means our rejection rate becomes almost 85 to 90%. But out of these 110 articles, these are the award-winning papers. So I'm really happy to share with everybody Dr. Piley and Dr. Atulya's papers. It will be really, really very, very helpful to us in our clinical practice. So thank you, madam, once again for accepting the invitation and giving your advice to all these junior. Thank you once again.
Thanks.
Thank you so much, madam. I think Dr. Sunawala has joined us. Can I please have his intro slide again, Aarti?
Yes, madam, I'm doing that. Give me a second.
Yeah, our second guest of honor today is Dr. Rustam Sunawala. Sir is consulting obstetrician and gynecologist. He's Professor Emeritus at Wadia Maternity Hospital, Parel, founder president of Indian Society of Prenatal Diagnosis and Therapy since 1989, honorary medical director of Family Planning Association of India, chairman of Tata Memorial Hospital Ethics Committee, president of FOGSI in 1996, and he is a founder member of various societies of India and is the recipient of various awards like the Von Grafenberg Medal, Padma Shri by the President of India in 1991, Rashtriya Samman in July 2002 by the Income Tax Department, and Dhanvantri Award in the year 2014. We welcome you, sir. Sir, is it possible to unmute yourself? I don't think Sir is was struggling to join. I think he's still seeing how he can unmute himself. Meanwhile, I request my Assistant Secretary, Dr. Sunil Tamvekar, to introduce our chairperson.
Good afternoon, everyone. Respected seniors, dear delegates, and senior faculty members. So, as Neil deGrasse Tyson once said, the good thing about research and science is that it's true, whether or not you believe in it. These are the principles we believe in as far as research and science is concerned at JOGI. It's my proud privilege to be part of the program and take program ahead with introducing our senior chairpersons. Dr. FOGSI Louis, he's senior obstetrician and gynecologist, associate professor from Amrita Institute of Medical Sciences, Cochin, Kerala. He's been senior leader. He had been vice president of FOGSI 2021. Many leadership posts at ISAR, IAG, ICOG. He was governing council member 21-22, Kerala chapter ISAR, and has been leading various committees and roles at various levels at FOGSI, and many research, as well as awards to his credit. So thank you for joining, sir. I would like to introduce our senior faculty member, Dr. Vidya Thobi, madam, senior leader at FOGSI. She was a president of Karnataka Society of Obstetrician and Gynecologist in 2023. She's vice president-elect 2024 for FOGSI, heading various committees and being chairperson for the various posts for the FOGSI, ICOG. Thank you very much, madam, for joining us. I would like to introduce Dr. Professor Sumitra Yadav. She's senior obstetrician and gynecologist, practicing as well as having many various teaching posts at her credit. President of Indore Obstetrics and Gynecological Society 24-25, was a part of FOGSI MTP committee, executive member of various FOGSI committees, and many awards to her credit. Thank you for joining us, madam. Okay, I think Dr. Rustam sir has joined. Sir, we would like to hear your notes.
Hello.
Hi, sir. We can hear you. Please go ahead, sir.
Yeah. No, I'm sorry. I took a little while to join.
No problem, sir.
My iPad was failing. We changed the iPad and I'm able to join. I would just wish the webinar all success at the moment, and maybe after the webinar is over, give my comment. But the very fact that these webinars can be used all over India is something which is really very educatively an advanced procedure. And each and every speaker must have worked very hard. I hope there is more participation. and wish the webinar all success. Thank you. Thank you.
Thank you very much, sir. It's our privilege to join and be with you here. Madhuri madam, you want to say something?
Yes, yes. R.P. Sunawala sir is a very, very senior, sir. And, as the Dr. Kamal Bakshi and Dr. R.P. Sunawala interacted with them, and they are God to us. They are always, their blessings are always with us. And sir, thank you for joining, and you have really, really, it is encouraging when you join, and we feel like working more and more. So thank you once again for joining, sir.
Thank you, madam. So hereby I request chairpersons to introduce our first speaker, Dr. Paili, sir.
Good evening to all. I think respected chief guest Dr. Jaydeep Tang, Madhuri Patel madam, and guest opponents Kamal Bakshi sir, madam, and Rastam Sonawala sir. I think I take this as a proud privilege and humble to introduce our first speaker of today, my teacher and my motivator to go into this gynec profession, my teacher Paili sir. I think sir doesn't need any introduction to any gynecologist in India, but as a formality, I like to introduce. And sir is the national president at present of the Society of Vaginal Surgeons of India, past president of Kerala Federation of Obstetrics and Gynecology. I was privileged to work as a secretary under him during his presidency. State coordinator of confidential review of maternal deaths, Kerala. It is a unique program which sir is being heading. Sir's vision is that CRMD of Kerala is doing for many years, and sir is also at present the senior consultant of Rajagiri Hospital Alway in Ernakulam district, Kerala. Special interest is high risk pregnancy, endoscopy, pelvic floor, and urogynecology. I think we all are, a lot of people are inspired by SAR's academic interest, SAR's discipline, SAR's meticulous way of seeing things. And even now, SAR has done this work, which has been which has been selected as one of the best articles of the JOGI in the last year. I think SAR will be giving a highlight into that, and the topic is crash cesarean delivery, how to optimize decision to delivery interval by initiating a novel code and clinical audit. Over to you, sir.
Thank you very much, Jogi as a whole, and Jaydeep, Madhuri. It was a privilege actually to have Dr. Kamal Bakshi as well as Dr. Sunawala as the chief guests of the day. We are really honored because these two stalwarts, going back to decades, still maintaining their contact with the profession is amazing. It's an honor, Bakshi madam, as well as Sunawala sir. And of course, thank you very much, the Young Brigade, FOGSI particularly, because he is representing Kerala in most of our FOGSI activities. Vidya Tobi, thank you, Tobi, and Sunita Yadav, and also Sunil and Bretnia, the Young Brigade. Thank you all for this opportunity. Let me get to my topic of the day. If I can share, can I?
So you can share the screen.
Okay, can you see? I hope you can see.
Yes, sir.
Yes, sir.
Okay. We chose this topic because of its practical importance. As the heading itself implies, crash cesarean delivery, how to optimize the decision to delivery interval. And all practicing obstetricians will agree that this is a real burning problem, especially when we are faced with a emergency. Like, for example, you do the CTG, you get a prolonged bradycardia, or you do a PV and find cord prolapse. Or if you suspect in a previous cesarean in trial of labor that the uterus is ruptured, or you see blood coming out of the vagina with the baby still inside. In all these situations, we are forced to deliver the baby immediately. And that is why internationally, the class 1 cesarean or the emergency cesarean section has been brought in. But internationally, for all practical purposes, what they have suggested is you should try to deliver the baby within 30 minutes. I feel that this may be a compromise because it is not easy in most of the settings to get the baby out faster. But we believe, and I hope all of you will agree, that even 30 minutes is too long a period for the welfare of the mother or the baby or both. For example, it's a prolonged brady. Unless you take the baby out within about 8 to 9 minutes, and if the baby is cut off from the supply of oxygen, then you get a dead fetus. So we thought that even 30 minutes is too long and we should strive to bring it down. And I hope all of you know that internationally, there had been attempts in various centers to bring it further down. And we thought how feasible it will be in our setting. We put a target of 15 minutes. It's a little too tight, very difficult. But then after discussing with our colleagues at the allied departments of anesthesiology and neonatology and our own departments of nursing, and all of us together, we thought that it will be feasible to do that. And we wanted to try it in real terms. And that was the basis of this paper. And we thought that the best way to summon help promptly is to have a public address system. Why it is so? Because even though everybody will be carrying a mobile and all that, very seldom by phone call we can get all the people who have to come immediately to help the situation. To get the message across to them by telephone may not be correct. So that is why we thought the code system, as is practiced in modern medicine all over the world, like code blue, if we announce that, that would be the best way to achieve that. That we coined the term code 10 crash cesarean for this purpose. So multidisciplinary discussions between departments of anesthesiology, neonatology, and nursing staff was conducted. And then we did propose this to the Institutional Ethics Committee, which gave the go-ahead for that. We put it for a trial for 6 months and found that it is feasible, and then decided to start it in practice from the 1st of August 2020. We thought of sharing our first experience in the last 15 months, putting as objective of decision to delivery interval of less than 15 minutes. And by that, to decrease the maternal and fetal morbidity as well as mortality. That was the purpose. The indications for which code 10 crash cesarean was suggested was when we find an acute fetal distress, bradycardia, a severe antepartum hemorrhage with the fetus inside, a cord prolapse, or suspected uterine rupture. These were the clinical scenarios where we thought we will have this code activated. So if you look at this, you can see the flow chart. The labor room and first stage or second stage, the obstetric team will be there. And we then announce a code 10 crash CS labor room, the location in our hospital, that's the second floor, tower 2. We expect that the anesthesia team, the obstetric team, and the neonatology team will then go to the labor room theater, which is adjacent to our second stage labor room. We hope to get the baby delivered in about 10 minutes incision time and delivery in about at least 15 minutes. So this was the whole thing. And then assess the fetus and do that. So the staff involved are the obstetrician, of course, the obstetric nurse, anesthesiologist, neonatologist, and neonatal nurse. The operation theater will have the anesthesiologist and his assistant, the scrub nurse, circulating nurse, obstetric and gynae nurse, the obstetrician, neonatologist, and our own nurse. So then we analyzed our results in the first 15 months. All consecutive patients for whom we activated the code 10 were analyzed. And we found that in that time we had 25 occasions of calling for the code 10 crash cesarean section. Out of the total, 7 were for abruption, 2 were where we suspected uterine rupture, 5 were for cord prolapse, but the major chunk was from acute fetal bradycardia on the CTG. The characteristics of the study population, age was 29, primaries were 74%. Decision delivery interval could be achieved, that is below 15 minutes, could be achieved in 92%. The average was 13 plus or minus 6. And the question usually asked is, okay, you may be able to do it in the daytime, but what about the night time? So we analyzed it separately. During the day hours, the average time was 12.5 minutes, whereas even during the night, we could do that in 13 minutes. The pH less than 7 at birth was present only in 3, but we are glad to note that all the babies were saved. Regional anesthesia was used only in 4, the others it was general anesthesia. So this is the observation that we made. We looked at the point, what are the reasons for prolonged decision to delivery interval? What delays our execution of the desire to do an immediate cesarean? Very often it is at that time going and getting informed consent. For cesarean, we need a catheter to be put in. That will take its own time. Transferring from the labor room where the patient is to the theater table takes time, shift to the trolley and then back to the theater table like that. Or it may be you have to summon the help of all these concerned specialists, anesthesiologists, the scrub nurse, circulating nurse, all the other neonatologists, all these people have to be summoned. And very often sending messengers or anything will again take longer time. And the question is the theater ready round the clock at any time of the day or night? So to overcome this, what we would suggest is, first of all, in an emergency situation like that, you don't have to go for a detailed consent in writing. But the patient as well as relatives have to be informed about the development. What we thought was the obstetrician, whoever made the decision, doesn't have to go for that. The assistants can be told, this is the situation. For example, suppose we find a cord prolapse, the obstetrician who did the vaginal examination staying there, convey the message to the relatives, as well as in a very quiet and unhurried fashion, we can tell the patient that this is the problem. Baby's heartbeat is okay. We have to take for an immediate cesarean. And the relatives can be asked for the consent to be signed. At admission itself, we should take an open-ended consent saying that if there is an emergency, we have to do a cesarean. So that is what the consent, how the time wasted on consent can be reduced. But we should make sure that the people are told what was going to happen, and we should not make them worry too much. We should not create panic. Catheterization is the other thing. If you then go for all these typical aseptic precautions to do the catheterization, again going to take a lot of time. So what we suggested was, whoever is the obstetrician deciding that a crash cesarean is required should stay there and do it. All that already the vaginal examination already painted. So you take lubricant, introduce at the external meatus, and yes, change of gloves, or without changing the gloves, holding only on the plastic sleeve of the catheter can be introduced, and immediately that time taken can be reduced like that. Shifting to the OT, this is the most common reason for delay. Patient may be already tied to various monitors, IV lines and all that. Same thing applies to our labor room as well. But what we decided was, we will not have in the labor room beds which cannot be wheeled out to the theater. So we changed all our delivery beds to sleeker, narrower beds, cushioned surface so that patient is comfortable, but it can be wheeled out and then taken to the theater like that. So that takes away the time shifting to trolley and then back to the theater staff. Summoning staff, of course, with the public address system, we will call them. Theater readiness, The theater attached labor room always has a cesarean bundle ready. So there is no further delay. Just open it. It's already there. So this is how we thought we will reduce the time spent from the decision to the delivery and reach the target that we had. So in conclusion, if I could say that a rapid response system which can be replicated in ordinary setting is what we tried to implement, and we found that it is possible. Our decision delivery interval turned out to be 13 minutes, but this was about 2 years ago. We are still continuing to do that. We have now accumulated about 70 patients, and the average decision delivery interval could still be brought down to about 10 minutes. So it is very much doable. And if there is time, I can show you a video clip. How this is in practice done. So, Chairpersons, if there is time, I can show you a video clip. Is it possible?
Yes, sir. Yes, sir.
Please, sir, please.
The identity is covered, and you can see that nobody is running, but they have to walk brisk. Actually, here, this is the daytime when this happened. So we have hearing the code. Most of the people came, so we have too many people over there. It's the same delivery bed where the patient is lying, so the door has to be wide enough, and the theater.
Sir, we are not able to see the video.
But I think first, sir, we have to stop sharing the PPT.
Or else
Yes,
you
and then he
can
has to
have
share the
complete
video.
share. Or else you can have complete screen share.
Yeah.
No, Hachi.
Can you see now?
Yes, yes.
Yes, sir.
You can see that hearing the code, people are arriving from the theater and from the neonatology section, and of course labor room staff is there. Patient is being wheeled out. The person who decided to call the code has already put in the catheter. The same bed where the patient was lying is wheeled out and is taken all the way to the theater. All of our staff will be on the scrubs in the labor room, so they can take the patient to the theater. The patient is being wheeled into the theater. The theater table is already there. And they are on scrubs, as you can see. And the surgeon has already scrubbed. Neonatologists are arriving, and in our theater there is always the baby warmer and the resuscitator there. Patient has to be shifted to the table, for which we can use a roller or a fiberglass slide. Roller will make it easier. And the bundle is opened, and the bundle will have the necessary gowns and all the instruments for doing a cesarean. And the assistant is ready to paint, waiting just for the patient to be transferred out to the delivery bed, for which we'll use the roller. So the roller will help for preventing the modesty of the patient. We have actually made it unidentifiable, the patient details, but you can see that the patient is being transferred to the to the operation table with a roller. You can also use a fiberglass slide.
Actually,
The delivery bed is being taken out.
patient name, okay.
Because the patient is not fully covered, we are actually masking the view. But you can see what is happening. Patient is, the abdomen is being prepared by painting, done. Light is brought in. Pottery has to be connected, that's being done. Meanwhile, neonatologist has come and they are getting the resuscitator ready. Patient has been put under general anesthesia by the time the painting is over, so that the surgeon is able to drape as well as incise on the skin immediately, because the anesthesia people are ready to give a crash infection. You can see the tube is about to be inserted, electrical tube. Meanwhile, the neonatologist has come and they are getting the baby warmer as well as the resuscitator ready. Disposable drapes are anyway available, so they are being used. And the surgeon is taking over. We can do a transverse incision because that is what we do regularly. And even in the hurry-burry, you can see that the scalpel is handed over in a kidney tray rather than directly. Meanwhile, the neonatologist is checking the gases. The warmer is on. The towel to receive the baby is being warmed. Incision is being put. Go by the Gavladak technique, you just mainly stretch and open rather than cut all the way. So, stretching to both sides. The obstetric forceps will be kept ready, but in this case, I think we did not need it. In case there is difficulty to deliver the head, you would use the forceps or the ventouse, but forceps will be quicker, and so that is kept ready. So you can see that there is no undue hurry as you look at it. This is unedited. We have taken now I think it is about 6 minutes from the time we saw the first, it is 6 minutes, 5 seconds from the time we started. So no unnecessary hurry compromising the safety, and the baby head is being delivered out. Yes, it is already out. So that's about just under 7 minutes. It is 6.5 minutes only from the time you saw people coming in, and the baby has good tone. Cord is being clamped, and the baby is ready to be handed over for resuscitation. you can see the baby crying. So this was totally 7 minutes, 20 seconds taken from the time we started. And so just to show you that without undue hurry or compromising safety, we can still deliver the baby in a shorter time. And as I said, we have now found that it is possible to do that in about 10 minutes. But of course, we have to admit that ours is, I hope you can hear me.
Yes,
Yes, sir.
sir. Yes,
Yeah,
sir.
yeah. Without compromising safety by unnecessarily hurrying around, but at the same time, without wasting time, with people assigned their own responsibilities, and then we can achieve decision delivery interval in a shorter period. All the more reason in modern obstetrics to achieve that, because if you have longer period after an event like a prolonged bradycardia has occurred or a cord blast has occurred, the baby may be compromised, which is what we wanted to avoid. Thank you very much, Madhuri and team, for allowing us to present our experience here. I have my colleagues here, Dr. Ambujam, who was the surgeon in that, Dr. Raji Raj, who is my co-author, and it is the whole department's work. I am only just presenting it. Thank you very much for the opportunity. Thank you.
Sir, it was an excellent presentation, I must say. And really, it is a teamwork as your video depicted it. And you have got very good team. And many of our centers, they have lack of manpower. Only, but that requires lot of coordination. Yours is a tertiary care center. You have got all the neonatologists, anesthesia, everything. And that's why you could achieve it. But definitely, people are asking why this number, it is named as code 10. So if you can answer that, or it might be a ICD system or something like that. If it is, it can be answered here.
Can I answer that?
Yes,
Actually,
sir. Yes,
this
sir.
is
Yes.
a code which we thought about new.
Yeah.
And in our hospital, we thought that we have a code 7, for example, for stroke
Yeah.
patient being brought in.
Yes, yes.
Code blue, code red, code
blue.
black, code, everything is taken over. Colors are taken away. So we thought we will probably go to numbers. And code 10 doesn't have, it can be very much code 11 or code 9, doesn't really matter. Code 7 is already taken over by our neurology department. So we thought we'll take the round figure code 10, that's all. But some code, which is known to all the staff in the hospital, is what we require.
Sir,
And
that is an institutional code that is not recognized by any system.
Yes, this is true. We have developed it, but once we identify that this is workable and useful, then we can think about spreading it further. This is something which we try to promote in the state of Kerala as well, but not necessarily code 10, because everybody may not know code 10 what it means. So that is why we added to that the crash cesarean along with that. Because we may have anesthesiologists coming in new, neonatologists coming in new, and if you just announce code 10, they may not respond to it. That is why, along with that, we say, once it is universally accepted, I'm not particularly saying it should be 10. Some code for a crash cesarean is required. If FOGSI can take the lead, or International Federation can take the lead to have a code, that will be certainly useful. That is my message.
Thank you, sir. And if you can share some checklist, or we can roll out this your study in various centers also across the country, and we can find out what it really matters within 10 minutes what we could see. And many times we lose babies in cord prolapse or accidental hemorrhage and all those things. So definitely it is going to help us a lot. I need Dr. Madhuri madam's comments, and even Kamal Bakshi madam is looking at us to make comments on your such a great study, sir. Thank you very much. If they can share their experiences about any cases.
I must compliment Dr. Pali for this
Yeah.
nice topic, but I would like to, at the same time, I must admire that he has
Yes.
halved the efforts. What was internationally 30 minutes, he has made it to less than or equal to
10.
15 minutes. That is something that is commendable. But I would also like to ask him that supposing that the OT is busy, because that is the usual thing that happens in tertiary centers like us. Now, what do we do in such a case? What did they do in such a event.
I think they are set under separate operation theater or what?
Yeah.
No, but,
We have,
in tertiary care centers, like our
I
center,
get
we
it.
have at least 90 deliveries per day. And it's a huge amount of turnover, although we have
Yeah.
2 dedicated obstetric OTs, but at times it is not available. I would like to ask his views.
yeah, thank you very much, Sumitra, for asking that. What we have decided and done is we have only about 150 deliveries a month. So that way,
That's
yeah, but still we have a labor room attached, a theater attached to the labor room. That will
Okay.
not be taken for anything else if there is a patient in labor. But as you
That's
said,
that.
there can be 2 emergencies coming. A rare coincidence if it happens. The same floor has our main theater complex, which has got another 8 theaters, and 1 floor below we have another 8 theaters. So if the theater adjacent to the labor room is taken over by some another case of example, for example, another emergency, then the understanding is that whichever table falls or can be made vacant out of the 17 will be then taken over. But thankfully, we did not have an occasion to do that. Of course, I do admit if you have 90 deliveries a day, then compared it with about 5-7 deliveries in our, it's an entirely different thing. But what is going to happen and what is happening already across our country is that more and more centers are equipped with a tertiary care level. And even they, unless they put their actions together with the aim to achieve such a target, you will lose time. The code, the public address system is available in most of the major hospitals. But unless you have a code developed and agreed upon, then summoning people takes a long time. That's the most
I
difficult.
appreciate this thing, and I would, like Dr. Vidya said, that I feel that it is so good that this should be practiced all over India, not Kerala alone. This is something that will help all of us.
Sir, this code 10 can be interpreted as 10 minutes also, no?
Yeah,
I think
it is.
that
I
is
think so.
promoted
I
as
think so.
as
I
a
think
That is
promoted as 10 minutes. So
that
that
is
no,
at
it
the
will be
moment, but FOGSI, that is actually taking it too tight because you know that it is so difficult to have a decision and get the baby out in 10 minutes. Ordinary setup is difficult. So if you put a target like that, there may be medical legal implications. I think 15 minutes will be a more reasonable target
15,
when you
code 15.
think of the length and breadth of our country and the various types of hospitals. When you say 30 minutes even, and there have been other studies across the world where they said that it is not easy to achieve 30 minutes in many of the developing countries and developed countries also. So if you say 30 minutes should be your target and you deliver a baby in 45 minutes, there is other implication also for medical legal angle. So I would say that even though we should try our best to have the minimum DDI, that's a decision delivery interval, at the same time, there may be things beyond our control from the practical angle. And so maybe 15 minutes will be more realistic. Even though we were able to achieve 10, I wouldn't say that that should be put as standard.
Sir, I would like to comment, sir. I must congratulate, for the excellent, work you are doing. And I have been with sir since many, many years. And, he is into reduction in maternal mortality and perinatal mortality. And if I have to talk about the maternal mortality, which is not a platform, but I would definitely like to speak about that they, at the individual level, few of the senior gynecologists started doing a maternal death, auditing. And, today their maternal mortality rate is about 26 per 100,000 live birth. It was 19, but at present it has little bit increased. The reasons are they are different. They're trying to find out it. But I must say, Kerala is always in forefront for everything. And I must thank for that Sir Pally, that he is always a front man to reduce these MMR as well as the perinatal mortality rate. And sir, with your innovation, I feel this code 10 and what your result, crash cesarean section. So everybody is aware The cord tail is for the crash cesarean section, and indication he mentioned, these are the most important indication where you have to deliver baby as early as possible. Delivering a baby, which we saw in video, in 7 minutes without hurrying up, with remaining calm. Even the surgeon has to remain calm, and baby could be delivered, and there was a good output. They have taken for reason of bradycardia, but baby cried, without resuscitation. So that is the most important part. I think everybody, because we have many professor and head of the department, Dr. Sumitra and Dr. Vidya. Of course, FOGSI is also doing good work. So, and Madam Bakshi was always there as a head of the department. So, it is the inspiration to all of us that when we are working in our institute, we have to do some innovation so the benefit is given to the woman, mother, and the baby. So this is a great innovation all over India, all over the world. We can start such type of thing, and as Sir said, they have, customized the beds which can be built to the operation theater. That is also very, very important part, because sometimes we don't get wards boys and all to ship the patient. So this is taking a miss that used to take away the time. But now, because the cords are made such a way, they can build in that anybody can take the cord to the operation theater. I was working at the teaching hospital, and we always had, and now I'm at Wadia Hospital as an honorary, we always have operation theater next to the labor ward. And secondly, we have neonatal unit also next to our labor ward. Of course, in Wadia, we have on the same floor outside, but we have to just press the button that we are taking for cesarean section. So everybody runs in, and as far as the anesthetist is concerned, we keep always one anesthetist, free. One is working with the doing the operation. The other anesthetist is always standby. And as Dr. Sumitra says, they have 90 deliveries per day. It is a very big number. So cesarean section are also happening, 60 to 20. So every time we may not get, table. So Dr. Sumitra, we can request your authority to have an extra table, because when I was working in a JJ hospital, we had a separate unit and separate building. Our main surgeon, theater was in the other building. Still, we have shifted few of the patient, not in emergency, but not as crash emergency. We have shifted and done. So you can, request your authority to have a extra table, so that can
Yes,
really
ma'am.
solve your problem.
We
And
have asked for 2 tables more,
yeah,
2 theaters.
yeah. So these are the things, as Piley sir has done internally, and manage everything. So similarly, this gives us a chance to think in how to optimize maternal and fetal outcome. So we are always there waiting for your innovation and implement ourselves in our institute. Thank you once again for coming and presenting yourself as such a senior level and giving us, understand and, implement in future for ourselves and our patient. Thank you, sir, very much for your presentation. It was an excellent delivery.
Dr. Madhuri?
Yes, sir.
Yes, it was very nice. I would say very systematically and beautifully planned, from A to Z. Now, when I got retired from AIMS, and we had a patient who was transferred to Apollo because of a central placenta previa by plane. So anytime if she could bleed, it would have been a problem. So what we did is, I told my nursing and the anesthetist staff that if in case because there is, even if 1 table or 2 table is reserved, it is used by others, at times no table. So I said, we will ring a bell, and that bell will be an emergency bell. Throughout the hospital, it will ring just as an emergency. And at that time, that the OT should be ready, and in our 3rd floor, the sister with the IV set, cannula, catheter, everything to be ready. And in the OT table, the anesthetic, and all agreed. And one day this patient bled, so same emergency bell was rang. The patient was, the IV was started to her. She was shifted to the table, and we could achieve. So that centralized way also we did it. Here, doctor, I like the way code was created. There we said just the emergency bell and the hospital will give us without saying that the bed is available. That was just an experience.
Anybody would like to share the experience? Vidya, Dr. Sumitra, Pesi, their experience?
I do work in a tertiary care center only, but many times we feel that the anesthesiologists are at shortage in the district hospital where the burden is more. So we should develop a team of anesthesiologists also who can have a separate team of obstetric anesthesiologists. What I feel is they are posted, though they are posted in the department, they have put in on a rotation. But when this code 10 or code 15, whatever it may be, we want to implement, I think that should have a separate team only. And it all will depend on the burden, how much we are catering at our tertiary care center and what emergencies we are catering in our hospitals. So if really the outcome when we are implementing this code, we can have a good study on this code and implementation. So
In fact, you're right.
really
I
it
was
is a
thinking,
great one. Yeah.
I
And
was
how
thinking
it
about the
can
same
have
thing.
an effect on the perinatal and maternal morbidity and mortality. Both the
I was
things
thinking about
very
the same thing about the anesthetist, because usually when
yeah.
you tell them they are busy somewhere or the other. Now,
Ah,
fortunately for us, ours has become a women's hospital.
yeah,
Because
separately.
we were having a lot of issues there. The beds were less. So though they made it 6-floor hospital, still we are short of beds now again. And although the anesthetists have increased, so when Dr. Paili was giving this, I was thinking that can we dedicate one anesthetist as an emergency anesthetist? Won't be allowed into other things or may help there, but if there is an emergency, he is free that he leaves that and goes for the emergency. We'll have to plan it out in that manner.
Yeah,
I
we
think.
have to have a dedicated team, and that should coordinate at right time, at right place. Both the things are important. Let us
Right.
look
I'm
forward.
so happy,
And
Dr.
really,
Sumitra.
I must congratulate Paili sir to bring out this study, and really it is eye-opener at various places. We can just do this implementation of this study. Yeah.
Sir, I'm so happy that with your presentation, our two HODs have started thinking that what we should do and how we can come out with a good thing. So this gives us the inspiration to think that what we can do best. So this is the whole idea that, any student also can take the inspiration from this, study. Anybody, why student, anybody, our faculty can do it and they can do their studies. So this is the most thing, interactive session, which makes many of us to do such studies. And for that, I'm really thankful to Paili sir and all my chairperson, Pesi, Vidya, and Sumitra for the excellent, inputs. And of course, Madam Kamal Bakshi is smiling, but she has given us such a good, her example of the patient that we can really achieve if we wish to. So we all wish that we should give the best to the mother and the baby.
Oh,
We can go ahead with the second case.
Yeah.
okay. I think can you share the CV of Adulya?
Dr. Atulya.
No, I think not open the. Okay.
Not opened up properly, yes.
Okay.
Yes,
Okay. Can I introduce Adulya?
you can.
Next we have Dr. Adulya Shajan. She is a consultant, Department of Reproductive Medicine, and she did MBBS MS from Jubilee Mission Medical College and Research Institute, Thrissur, fellowship in reproductive medicine, and awarded Gynec Endoscopic Institute from the Kidney Disease and Research Center, Ahmedabad. Publication is authored chapters in renowned textbooks and multiple national and international research publications in Scopus and PubMed index journals. And professional engagement is presentation at international and national programs, FIGO World Congress, and All India AICOG. I think Adulya will be presenting on maternal and perinatal outcomes amongst nulliparous singleton pregnancies electively induced at 39 weeks, a prospective observational study. Over to you, Adulya.
Thank you, sir. Am I audible?
Yes.
Okay, so I would like to thank FOGSI and JOGI for this opportunity and this great initiative. A very good afternoon to the chief guest, Jaideep sir, Madhuri Patel ma'am, our guests of honor, Dr. Kamal Bakshi ma'am and Sonawala sir. Good afternoon to the chairpersons, Dr. Fesilu sir, Vidya Topi ma'am, Sumitra Yadav ma'am, and our own Paili sir. Can I share my slide?
Ma'am, you can share.
Is it visible?
Yes, ma'am, it's visible. Slide mode is required.
Yeah. Is the slide moving?
Yes, ma'am.
Yes.
Yeah. Thank you. So our study was on maternal and perinatal outcomes amongst nulliparous singleton pregnancies electively induced at 39 weeks. It was a prospective observational study and we called it EIOL 39. So usually preterm and postterm deliveries are associated with significant maternal and neonatal morbidity and mortality. There was a clear obstetric consensus for induction at 40-41 weeks, but there was uncertainty for induction of pregnancies beyond 39 weeks. So the ARRIVE trial, which was published in 2018, was studied on low-risk nulliparous women. They randomly assigned women to two categories, the induction group and the expectant management group. And they found that induction beyond 39 weeks, there was no significant reduction in composite adverse perinatal outcomes. And this elective induction was associated with significantly lower cesarean section rates. So there was a research gap where the ARRIVE trial participants may not represent outcomes in other settings, such as ours in South India, and there was limited evidence to guide recommendations for elective induction of labor at 39 weeks in nulliparous patients, particularly in pragmatic settings. So the objective was to evaluate the maternal and perinatal outcomes of elective induction at 39 weeks in South Indian population of nulliparous women. So once full term, many authors have recommended induction of labor in uncomplicated singleton pregnancies, and our institute also followed a similar policy. So the aim was to study maternal and perinatal outcomes at 39 plus 0 to 39 plus 6 weeks amongst nulliparous singleton pregnancies electively induced in our tertiary care center. It was a prospective observational study conducted over a period of 18 months from October 2019 to April 2021 in a single tertiary care teaching institute in Kerala, South India. It was approved by the ethics committee and the study was registered under the clinicaltrials.gov. So the inclusion and inclusion criteria was nulliparous patients with no previous pregnancies beyond 20 weeks, singleton gestations, undergoing elective induction between 39 weeks and 0 days to 39 weeks and 6 days based on clinical information and evaluation of the earliest ultrasound and consenting to be part of the study. Exclusion criteria was planned for cesarean delivery or any contraindication to vaginal delivery, a fetal demise or any known major fetal anomaly. So our outcome measures, the primary maternal outcome we measured was the incidence of cesarean section. Secondary maternal outcome was the time to delivery, incidence of chorioamnionitis, incidence of postpartum hemorrhage. So the primary perinatal outcome was admission to neonatal care unit requiring respiratory support, and the secondary perinatal outcomes were neonatal mortality, Apgar less than 7 at 1 minute, and meconium aspiration syndrome. So all the patients admitted to our labor room during this time frame, to about 2,139 patients, consent was obtained at any time between 34 and 0 weeks to 38 plus 6 to 7 weeks of gestation. And those meeting the inclusion and exclusion criteria, were almost 339 patients, of which 26 refused or withdrew from the consent. 8 patients were planned for CS or developed some contraindication for vaginal delivery, and 1 patient had fetal demise. And data were procured on a detailed preset performer. Of the final 304 patients analyzed, the parameters included maternal baseline characteristics and the primary and secondary outcome data with specific timeframes, a total of 69 parameters. So our primary maternal outcome, which was the incidence of cesarean section, out of the 304 patients, 80 underwent an emergency C-section, which was about 26.3%. The reasons being failed induction, about 33 patients had failed induction, 20 patients had CPD, 1 had arrest of descent, 7 patients had fetal distress, 1 patient had failed instrumentation, 16 patients had meconium stained fluid, 2 patients had cord prolapse. And our secondary maternal outcomes, the time to delivery was 19 hours and 42 minutes. There were no reported cases of chorioamnionitis. And we had 9 reported cases of postpartum hemorrhage, of which 3 required blood transfusion. All 9 required more than 2 uterotonics, but none of the patients required obstetric hysterectomy or any other surgical intervention for postpartum hemorrhage. The primary perinatal outcome was requiring NICU admission. About 15.8% of our babies required NICU admissions. But the secondary perinatal outcomes, like Apgar less than 7 at 1 minute, was 3.6%. Meconium aspiration syndrome was 2.9%. Requiring respiratory support was 4.9%. None of the babies had neonatal death, or there was no requirement of CPR within 24 hours of birth. And of the respiratory supports, 40 babies required CPAP, 46 required HFNC, and 2 babies required endotracheal tube intubation. So this is a summary of the results we got. The primary maternal outcomes, we had 50% of the patients undergoing normal vaginal delivery, and the other 50% we divided it between operative vaginal and cesarean. Almost 23.7% had operative vaginal delivery and 26.3% had an emergency CS. The average induction delivery interval was 19 hours and 42 minutes. There was no incidence of any chorioamnionitis reported, and 9 patients had postpartum hemorrhage. And requiring NICU admissions, 48 babies required NICU admissions, 9 had meconium aspiration syndrome, 15 babies required respiratory support, 11 babies had Apgar less than 7 at 1 minute. There were no babies requiring CPR within 24 hours of birth, and no perinatal deaths reported. So before induction, we had a cumulative Bishop score between 0 to 8, and after induction, it had improved from 2 to 10. So coming to the discussion, similar studies were done in the USA by Grobman in 2018, where a sample size of 6,096 patients were induced after 39 weeks and 0 days to 39 weeks and 4 days, and their cesarean rate was 18.6%. This was published as part of the ARRIVE trial, and they said it reduced cesarean rates. Their operative vaginal delivery was 7.3%. Incidence of chorioamnionitis was 13.3%. Another study in the UK by Walker et al. Had 618 patients induced between 39 weeks and 0 days to 39 weeks and 6 days with a cesarean rate of 32%, no operative vaginal deliveries, and incidence of chorioamnionitis were 0.3%. Another study in the US by Miller et al. With 162 patients had a cesarean rate of 30.5% with 3.7 operative vaginal deliveries and 14.6 cases of chorioamnionitis. In our case of 304 patients, a cesarean rate was 26.3% with 23.7% operative vaginal deliveries and no incidence of chorioamnionitis. The perinatal outcomes, with the 18.6 rate of cesarean section, the NICU admissions were 3% with no reported Apgar less than 7 at 1 minute and 0.1% perinatal mortality. In the Walker et al. Study, there was a 32% of cesarean section, 2% of NICU admissions, and 3.6% of Apgar less than 7 at 5 minutes, and no perinatal mortality. The study by Miller et al. With a cesarean rate of 30.5% had 6.1 NICU admissions, 0% Apgar less than 7 at 5 minutes, and no perinatal mortality. In our study of cesarean section rate of 26.3%, we had 4.9% NICU admissions, 3.6 babies having Apgar less than 7 at 1 minute, and no perinatal mortality. So, the major reason why many providers are opposed to elective induction of labor is presuming that cesarean delivery increases maternal morbidity and mortality. In our study, even though cesarean rates were higher, there were no maternal or perinatal mortality or complications like chorioamnionitis, and the women who had postpartum hemorrhage in our study did not require any massive transfusions or mechanical or surgical interventions. So, the hallmark of labor management in the present day should be individualized care for women in labor. Standard protocols and guidelines for induction of labor with careful monitoring intrapartum were followed, with the liberty to intervene with the C-section or instrumentation in this setting. This probably helped minimize our maternal and perinatal mortality in our study in spite of induction beyond 39 weeks, expecting a safe vaginal delivery with the ability and facility to intervene in the time of need. So, induction of labor at 39 weeks in low-risk nulliparous women in our population did not result in a lower frequency of cesarean delivery or in ICU admissions, but there were no reported serious maternal or perinatal morbidity or mortality. So, elective induction of labor beyond 39 weeks could be considered as a comprehensive strategy for patients who don't have easy access to healthcare to improve maternal and perinatal outcomes and to time delivery during convenient hours when maximum manpower is available. Future research, it was a single center studies. There was a limitation of our study, which needs further validation in other similar settings. And future studies should be undertaken to better determine an ideal time for elective induction of labor in nulliparous women in our population. And also, a wider inclusion criteria is to be considered, and a comparison group can be added with an expectant management group beyond 39 weeks in future modifications of the study. Thank you.
Madam, you can stop shares.
Over to chairperson.
Vidya madam. I think Adulya, that was a excellent presentation. So, Mr.
Hello.
Madam.
Yes, I just
Yes.
wanted to ask that when you were induced, you have not mentioned that at
The
39
methods.
weeks, what was the method of induction?
Method
What
of
was the
induction,
bishops?
Yes,
Did
ma'am.
it correlate with anything? You have,
Yeah, the
in
method
you
of
cannot
induction was
compare.
based on, sorry, ma'am. The method of induction was based on the Bishop score. And actually, method of induction, the first, according to the Bishop score, we had induced with extraamniotic saline or Follies on the previous day of induction. And the next day morning, we had given the patients Serviprime gel or misoprostol, depending on the consultant's preference. And 4 to 6 hours later, we had done an ARM and started oxytocin augmentation. So that was the
No,
protocol.
but how did you actually? There were two arms. One was with Serviprime and one was with
Yeah, ma'am, we
misoprostol.
did not
So there is
split that. Actually, the Serviprime showed more instance of vaginal delivery, but that would make the study very, very elaborate. So our focus was mainly just on the primary outcome of cesarean section. So we didn't split it.
And it is
because
very, very, very difficult to point out on the failed induction. In your
Mm,
study,
yes.
the definition
Yeah,
of
that's
failed
what-
induction also varies. And which criteria really you have applied? Because now 2024, the criteria is a little different. And
Yeah,
we have
every
got
4 hours.
WHO care guidelines also, no, for management,
Yeah.
intrapartum
So
management.
even after every 4 hours, if there was no significant expected change in the Bishop score, then we had counseled them for a C-section, ma'am.
That is induction by oxytocin.
Yes, ma'am. After starting oxytocin, every 4 hours, the Bishop score was reassessed. And if there was no expected improvement in the Bishop score, then we had counseled them for C-section.
No, so
Dr.
when I
Sudesh, you want to comment? You have raised your hand.
Please unmute. Maria, unmute Dr. Sudesh. Maria?
Gauri, please, I'm not able to unmute. Please unmute Dr. Sudesh Agarwal.
Am I audible?
Yes, yes.
Okay, okay. Thank you very much, madam. I want to congratulate Dr. Atulya. This is a very important study, and these studies are really required for our country. But there are a few queries, as we all are practicing obstetricians. As madam have rightly pointed out, if the Bishop score was good, that itself indicates that probably if we would not have, say, induced at 39 plus 0, she might have gone into labor by 39 plus 6.
Yes.
Every 1 day makes a lot of difference. The problem only comes when the Bishop score is poor. You have said the minimum Bishop score was 2. That is not a good one, even if you give some priming with the whatever method you use. And afterwards, if you are giving single misoprostol, we all are practicing, say, more than 25, 30, 35 years. So we all have these observations that in spite of giving misoprostol or Serviprem, the Bishop score does not improve that much. My personal opinion, though I have not done a study, what I have seen is that if I am giving Serviprem after a poor Bishop score and I want to really induce maybe some other indication like PIH or something else, within 24 hours, though nowadays I know the younger generation, they like to intervene very fast. But for a person like me, maybe many of my age group people, those who have worked in those days, will agree. We give Serviprem. Serviprem is basically not an inducer. It is only to prime the cervix. Then leave it for minimum 24 hours. So that the section is something like it is causing the softening, changing the collagen of the cervix. So it takes time to act. If we intervene too fast, I don't think if after 2 Bishop scores, the Serviprem you gave and you wait for 6 hours, it is going to make any difference. These type of things are that sometimes, yeah, these are the open facts. We all are gynecologists here. There are multiple reasons. Suppose one patient is to be taken for the cesarean, they are just said, okay, tum de do isko, you give the just Serviprem, and it is well understood at the back of my mind, after 12, I will be free from the routine surgeries and I will finish it off before I push to my home. That is the something. Yeah, we all have done once in a while of these kind of, and these kind of services, these kind of practices are rampant. We all have to accept. That is another thing. And second thing you said in the improvement of the Bishop score. See, if patient is already delivering, there is means what, how will you say? And we are really interested, how means is the duration. You said average is 19 hours, very well accepted, no problem. But that average will be changed a lot. As I said, the initial Bishop score was say 6 or 7. So within a few hours, she will be delivering. But where the Bishop score was poor, so though it is a very well studied, but you can probably modify a bit in the people who are having a Bishop score, say less than 5 or poor Bishop score. So actually those are the people we are really worried about.
Agreed, ma'am. Yeah.
It is my observations. Thank you so much. And you can probably highlight if you have some data that how these poor Bishop score people have done, what is the rate, what is the interquartile differences, because there must be some very many.
Yes,
and the indication for cesarean does not arise just like that.
Yeah,
Even if
I
she is
have the
not
data
responding
for
to
this and the
Serviprem.
prostaglandins also separately, ma'am. I'm analyzing it
You
now.
might be then again publishing that comparative
Yes.
studies, I think, Atulya.
Yeah, I
Isn't
have
it?
the data for all that.
Okay,
Yeah.
and this is also platform. May I take liberty? I am working on a problem of pregnancy-induced hypertension, and if few people are interested, I will write down my email ID and the phone number. Please contact me, so we can plan something in future. Okay.
Thank you,
Vidya
Dr.
Sobi ma'am,
Sudesh.
she knows about it.
Yeah, I know about it.
Yeah,
About your study also, I
I am
know.
also working with the ICMR sponsored or DHR sponsored some projects. Madam
See,
Madhuri Dixit ma'am, she also knows about it.
Yes,
Yeah.
very much.
So I am looking for, because what happens, some are from the south. They find it difficult whom to approach for the north people. And for north people, yeah, please don't mind it. We are not thinking, but actually it is a problem.
We will
We don't have
discuss
many phone
on
numbers.
some other front, Sudesh. We will have one Zoom meeting regarding this.
Yeah,
I
sure.
just
Sorry.
wanted
I
to
don't want to waste
congratulate
time here.
again
Yeah.
Atulya
I
coming
just
to our
write down my
journal.
number. Yeah,
Yeah,
number and phone
No,
number.
you put it in
Anybody
the
can
chat
contact.
box. You put it in the chat box.
Yeah, that I
Okay,
will do.
thank you.
Thank you so much, ma'am.
Thank you.
I have taken the liberty. Thank you.
No problem.
Thank you. Dr. Atulya, your studies really wonderful, I must say, though you have not mentioned much about the induction methods and all. People are afraid that after 39 weeks, induction will definitely land up in cesarean section. And most important is the counseling part, and when to label it as a failed induction. So what about the general practitioners? What do you want to give? Because all are not consultant, all are not working in the medical college. So after doing this study, what is your conclusion? Conclusion means you want to induce all patients who are very low risk and you want to induce them.
Ma'am,
And
it has to be
which is the
a
practical method?
yeah,
Which you
ma'am,
want to
it
follow?
has to be an individualized approach to
No,
every patient.
individually,
And
low risk, 39 weeks completed, and you are working where the monitoring facilities are available.
yeah,
Because
ma'am,
monitoring is very important. After you induce, you have to monitor everything. Yes.
yeah, if we are working in a center with good monitoring facilities, and if it's accessible to the patient, she can reach the facility. Like if she has a decreased fetal movement, she can reach fast. If that is the condition, we can let her go till term. We can keep monitoring her. But if she doesn't have good access, or when it comes to if it's not a good facility, they don't have a lot of higher things for monitoring, then I think elective induction would really help the patient and the consultant attending the delivery to time delivery in that convenient hour where every facility is available. That is the main advantage of elective induction, ma'am.
Yeah. So I think Dr. Madhuri would
I would like
talk
to
about the
talk.
Dr. Shirish Daftari and his program labor, and we have learnt about it, and really it is a wonderful thing to implement also. So
Dr.
any other
Sumitra?
comment from
Dr.
Sumitra?
Sumitra?
Yes, actually, hello.
Program labor.
Hello, I was a part of
Programmed
that
induction.
program labor. I have my own series here in North on that program labor with Dr. Shirish Daftari and Sham Desai. I've been a part of that. And of course, it has its advantages, but I just was not clear about certain things. So I just pointed it out. Nice study, and they can improve it further. They can have a better, I feel it can have a far reaching effects if they actually look into it, because a lot of people are worried that they'll deliver vaginally or not. So 39 weeks, I think it's a nice thing, but needs more clearer guidelines.
Yes, many times to know the correct gestational age is also problem.
Yes, gestational age should be accurate right from the first ultrasound and first this thing. Second thing is, of course, that they should be clear about even the score. At times they induce, and then there are issues that they overlook, including the pelvis, because that is also a very important part. So these all things are very important. Assessment of the fetal weight also, they induce, that should be written here. But okay, fine. Thank you very much.
Dr. Sunil, Dr. Facey, like Dr. Facey comment, and I would also like to ask Dr. VP Piley, sir, for his comments. Madam Bakshi is there? Dr. Bakshi is there? Dr. Sunawala?
I'm checking, ma'am.
Seniors. Let us hear comments from our seniors.
Thank you very much. Thank you, Madhuri, for asking me for our opinion on this. This is an area we have been working since 2000, and we had our initial results in 2004, but we put that as planned vaginal delivery at convenient hours and showed that it doesn't increase C-section rates at all. It reduces, in fact, the meconium staining of the amniotic fluid if you don't allow the babies to go beyond 40 weeks. But the problem is, what is emphasized of Adilia, congratulations Adilia for this study. And the most important aspect is ripening of the cervix. Even though we say misoprostol is a ripening agent as well, if you give it to an unfavorable cervix, it can cause contraction. So our own protocol is mechanical ripening first, followed by misoprostol orally and not vaginally. And then when the cervix has become effaced, if necessary stimulation further required, we go to oxytocin. I think that sequence is important. If you just have a cervix with a score of 2 or 3 and then go with meso orally or vaginally, you can have more and more problems. So mechanical ripening followed by stimulation followed by oxytocin if required. I think that should be the sequence. The concept that induction increases C-section rate is not correct, as was proved by the ARRIVE trial, as was proved by many of the other trials, and which we showed ourselves in 2004 studies. So that is my take on that. I think, but when you have a 39-weeker, as was pointed out, I think by Dr. Sudhir, as well as others, that dating is important, extremely important. You review even a 2 or 3 days difference because very important in the response that we can get. So I would suggest that we should recheck on the date before taking somebody for inductions and ripen the service first before we allow other agents like prostaglandins. Thank you very much.
Thank you, sir. Thank you, sir. Sir, Arti Sunawala, sir.
Yes.
Your comment, please.
No. Now, I've got some few points. In USA, even a C-section elective done at 39 weeks, one had to do amniocentesis to do fetal maturity as late as 80s and 85s. And we had a nasty experience whereby during amniocentesis in a twin, very, very precious pregnancy gone all the way from here to deliver in US, they did amniocentesis and punctured a major blood vessel and led to hemorrhage. And they luckily had the facility to immediately do the C-section. So the twins were saved. But the mother-in-law, the father, and myself, we were still in Bombay because the elected date was 2 days away. So this rule now, I don't know whether it still exists or not in US. At Wadi Hospital in the 50s, when I was working, we had 1,000 deliveries a month. Yet the cesareans were so few that whenever there was a C-section, they would be ringing a bell so that the junior doctors would be able to come and see the cesarean being done. The incidence of cesarean was around 5 or 7 or 10%. The multiparous women at that time were 5 or 7 babies coming for deliveries. The picture has completely changed. Now the people come with 1 kid or 2 kids and hardly ever a third baby, unless in the rural areas it may still be practiced. But both mother and father working, they don't plan for more than 1 or 2 children. So the picture has changed and individual cases have to be decided according to that. Now, at one time, we had a high incidence of mid-cavity forceps, phase 2 pubis delivery, kill ends, all that is obsolete obstetrics nowadays. Difficult forceps is definitely a trauma to the baby, not that it can traumatize all the babies, but even if 1 baby out of 100 is traumatized, that for that 1 baby, it is 100% trauma. So that one has to be very careful so that you deliver a baby without any trauma, cerebral trauma, which eventually leads to a permanent handicap in life. Now, I was working in Delhi at Max. To get the theater in emergency, especially during the day, is out of question. There'll be another person operating, he would not give you the theater. And these are cases where every minute matters. So at Max, Sake, we had 2 delivery rooms. The number of deliveries, I can't remember exactly, but were not so many. And 1 delivery room was equipped to do LSCS also. And it's not a big thing because the labor room itself is an area we keep as an aseptic area and all the formalities of a normal theater. So it was very practical. I've left Max since now 5-7 years, so I don't know whether the practice is still going on, but it was very, very useful. A patient in labor, you decide to do a C-section, you don't have to shift to another area where the operation theaters are. In the same labor room, the facilities were there for doing a C-section. And it is not difficult. Patients are under epidural, the anesthetist is there, except that the theater asepsis is a little more important than a labor room asepsis. I don't know whether it is still being practiced. At Breach Candy Hospital, where also I'm involved, we had 3 theaters which were mainly for obstetric gynae and general surgery works. So one theater was always kept empty for emergency cesarean. That was OT number 6. And if anybody wanted an emergency short case, it was allowed. But no major case was allowed. So that if you needed the theater, you had not to request the previous surgeon. You had not to wait for the theater to be empty till you get your turn. In the night, it is easy to get the theater. During the day, the theaters are rather busy and you don't get them at the last minute. So these are certain practices, depending on the institution, depending on how many deliveries you are doing, the facility for an emergency cesarean has to be thought of by providing facilities in the labor room itself or an emergency theater available at a very short notice. Now, I'm not criticizing. Please don't misunderstand me. The introductions that we are doing for each doctor is important, I know, but can it not be just projected and the highlights of that person are introduced? Because time is precious, and then more time will be utilized in more useful work than introducing a person and giving a long biodata of that person, which could be just projected and people can read, and the highlights of the performance of that particular individual are very important. So the introductions, JOGI has to look into to make them a practical introduction, a short introduction, giving all the highlights of that particular person's achievements, but not the routine of long introductions going on and on. I thank the organizers again for giving me this opportunity. Each and every participant and must have done a lot of homework to make these excellent presentations. And I'm a little bit upset because the number of participants, if you notice, is hardly 56. I think it's an all-India webinar in a country of India with so many obstetricians, so many gynecologists. A little more participation in these excellent programs should be somehow promoted. I don't know how we can do it, whether it's the timing is not suitable for everyone or they think it is not important. But even, believe me, after having worked for 60 years in obs and gynae, every time I listen to a person, I learn something new. So the learning process is never limited. And nobody can say, I've mastered anything. The day you say you have mastered anything, next day you will have a pitfall. So interest in learning should be a sort of a passion for every practicing doctor, not only obs and gynae, but all the medical, because now the advances in medical practice from what it was in the 50s after the Second World War. No ultrasound, we only had the fetoscope and palpation, and with a lot of worry, we would do an X-ray if required. And then ultrasound came in, and then the genetics, and then everything. So now the whole picture of the medical care in the last 50, 60 years has changed thoroughly. And one has to utilize the modern facilities in the best possible way. A safe delivery, a baby who is not permanently traumatized is what we aim at. The number of deliveries, 5 to 7 were a normal procedure. Now it is 1 or 2. So that I don't think we should be bothered if we end up in a C-section. But in a doubtful case, instead of doing a difficult forceps, I would definitely err on the side of a C-section. At the same time, in Bombay, there are institutions where the C-section rate is around 75%, which is unacceptable. A normal performance, 25 to 30% C-sections is an accepted figure, and not this 70 and 75% people elective C-section or anything like that. Thank you for the organizers for giving me this opportunity. Obstetrics is the most important branch of medical science. You are looking after a newborn baby. You are responsible for the whole life of the newborn baby, and a healthy delivery is what one would like, and that is our main responsibility. Induction at 39 weeks and all is, I think, the right approach at the moment, because more post-mature they become, the more problems it can create. At the same time, the ripening of the cervix and ready, as Dr. Pelli pointed out, is very important. A long conical cervix, unripened, you can do a short trial and give up if the cervix is not favorable for a long labor, landing up with a difficult forceps or vacuum forceps or whatever. A C-section at that time would be the right choice. Thank you for the organizers to give me this opportunity. And it is always a pleasure to listen to people, each and everyone who have achieved a great position in their own area, in their own institution. And I enjoy seeing all of them on this webinar. Thank you. Thank you very much.
Thank you.
Thank you, sir, for your very good input, sir. As you have started from 1950, what it was, and today we are in 1924, almost 75 years. So many things you have changed. As you said, the technology has advanced and our practice has become now technology based. We are more moving away from clinical practice and we are into the technology. That I'm admitting it, sir, today, because you have also from 1950 to 2024, you have given us the idea. Secondly, sir, what you said, the attendance is, you said more than 50. We are trying our best, because in a journal work, sir, only the few people, they are committed to attend this work of others, original work. Because if you look at the journal activities, we have started a clinical pulse, and we are also having a PICSEM program, that is research methodology we are conducting in different societies. We have to make our people research oriented apart from the clinician. Till we make them a research oriented, this problem is going to remain. And this, even 50 people Few of them will pick up our papers, best papers, and they can do the studies. But definitely we are sending SMS, we are sending email, we are also from the same, where we are conducting this, we are sending to all the 45,000 members to join in. As you rightly said, the time may be the problem or the interest may be the problem. So we will try to find out the solution and we will try to see that more and more people join. As far as my experience is concerned, I would like to talk to Atulya. That Atulya, when you said induction failure, you had 41.3% failure of induction.
Yes,
So I
ma'am.
just want to know how long you waited. Because in my practice, I put a cerviprime gel when the cervix is not right or Foley's catheter. And the Foley's catheter comes out, that means the cervix is at least open up 3-4 centimeter.
Yes.
And then you can put another cerviprime gel or start pitocin, oxytocin drip and do the ARN. In my practice, I put a cerviprime gel when the cervix is not right. After 6 hours, I assess. Still the cervix is not taken a good, ripen. Then I put another cerviprime gel. And, I don't take for a cesarean section because these are the low risk patient. She can wait, next day you can again, induce her, but you have to monitor the patient. And I have seen many times all these patients, they keep on getting little contraction and it makes the cervix right. And sometime at night or in the morning, they deliver themselves or with the oxytocin, they really help. So, here is the trend is that for 12 hours, the patient does not go into labor, take for C-section. So this is a low risk patient. We can always wait depending upon the monitoring of the patient and the baby. Secondly, you have done with the Foley's. I am surprised to know, I will not say surprised, but you have done a extra saline installation, extra amniotic saline installation. I have not seen extra amniotic saline installation. Our senior used to do the intra-amniotic saline installation for the second trimester abortion because we did not have prostaglandin that time. But there were, in 1 year, there were 4 cases of maternal death following intra-amniotic saline installation, and it was attributed as DIC. After that, this method was stopped. So now you have started doing extra saline installation, that was of 500 ml along with the Foley's catheter.
Yes, ma'am.
Usually, when the cervix is not right, usually it takes 24 to 48 hours for the contraction to occur. If it occurs before that, very nice. But there may be hypertonic, uterus, hyperstimulation. So have you experienced such thing in your practice?
Yes, ma'am. Hyperstimulation was more reported with cerviprime actually.
Not with the hypertonic saline?
No, not with the extra amniotic saline, ma'am.
Okay. So what you do when there is a Sir Paili would like to answer.
Actually, the extra-amniotic saline is normal saline.
Okay.
What you are mentioning is the
hypertonic
saline, 50% up to 50%. That causes tissue necrosis. And that is why we abandoned it in the, say, 70s when midterm abortions came in. And we abandoned it because of that. And then you remember there was urea, all those things experimented. This is extra-amniotic normal saline. It is actually extending the stripping of the membranes that we were doing. That is the basic principle of it. It brings in endogenous prostaglandins and ripening, adds on to the mechanical ripening part. That is how it is. It is not at all associated with hyperstimulation.
Right. Thank you, sir. Thank you, sir. Because it is a normal saline, yes, I agree that it will not create any much problem. But I want to know that 41.3% failure of induction. So I want to know then how long you waited and took for a cesarean section. I want to know that part. Because that 41.3% failure of induction is also very, very high. Could we have waited for this patient for another 2 days? Was it possible or not? I just want to know from you.
Yes, ma'am. Once we have ruptured the membranes, ma'am, then we are quite committed. So we don't wait more than 12 hours.
No, you are saying failure of induction.
Failure of induction of labor.
Yeah, if the Bishop score is not improving after ARM, even with oxytocin, maximum we give is 12 hours as long as the fetal condition is okay. And then after that, if the Bishop score is not improving, we decide on a C-section. That's when we
My
label it
question
as
is
failed
very
induction.
clear. My question is very clear. ARM can be done, at least cervix should be 1 centimeter dilated, right?
Yeah.
So
Yeah.
have you done ARM for all the cases whom you have done the induction?
Ma'am, yes, ma'am. ARM we have done for all the cases here.
So ARM done for all the cases, then we cannot wait for a long time. I agree
Yeah.
with you.
Yeah.
But why can't you
Ma'am,
try before ARM? Why can't you try something, make the cervix right? And
they
then
have repeated like a few cases. Like in my study, those cases have not come. But in our institute, we have repeated Serviprime and misoprostol, even not multiple doses. But in my study group, we have not had to repeat any Serviprime or misoprostol more than 3 doses.
okay. And I would have been very happy if you had done a comparative study. The patient
Yes.
would do spontaneous labor. It would have given a more idea because
Ma'am, actually, I'm collecting data for that now to compare it. I'm the institute where I'm working now. We actually go for expectant management, where most patients come in labor. So I'm collecting the data for doing a comparative study.
the comparative study has a more value because we know
Hello,
the
Madhuri. Good afternoon. Dr. Shobha Gudi here.
Shobha, yes, Shobha.
Hi. Wonderful, wonderful webinar. Very, very good discussions. And it is such a, privilege to listen to Paili sir and to Sunawala sir on this important subject. Now, induction is of labor, all of us, have experience. So I thought I will just say something here because of your dilemma about ruptured membrane and you know and then waiting how long, right? So current definition of failed induction actually is like that. It is unless we rupture the membrane and oxytocin drip of considerable duration, failed induction cannot be used as a definition to go ahead with cesarean. Maybe we can then have some other indication which is presenting itself, a non-reassuring fetal pattern or something else, right? So to say failed induction, we have to have a ruptured membrane. The current ACOG guideline says that, and I think it is endorsed by some other guideline also, probably the SOGC, that ruptured membrane followed by oxytocin infusion for 6 to 12 hours, provided maternal and fetal condition is stable. Then, then only the failed induction term should be used. That is how it goes. Now, considering...
Yeah, sorry, just a minute. Why should you do the ARM when there is no indication as such? Why should you make them to
That
go?
is where the change is coming up, Dr. Sudesh. That is where the concept is changing. Even I am the old school for ARM. I have always taught my PGs never to do ARM if it is risky. Yes, if you feel that the head still remains high and the cervix is likely to recede, etc., or if it's too posterior, then of course ARM cannot be done. I'm just setting the context for criteria to be fulfilled for failed induction. That is what I'm trying to say here.
Yes,
So ARM can
Yes,
be
Shobha.
done a little earlier than what we thought it can be
Yeah.
done. That is what I understood from from a lot of because
in the
even we
study
get
what-
plagued by that failed induction and consultants going ahead with cesarean. So there was in the latest conference which Dr. Jaideep Tang did, Dr. Ravichandran from Malaysia gave the oration, Dr. D.K. Tank oration on this very same subject, Madhuri. And what he said made a lot of sense. He said, is failed induction because of actual failure of the method, or is it because of failure to wait? So we should not fail to wait. That's the only thing. Because a lot of times we lose courage, and the family is too anxious. So probably we need to counsel the family in such a way that they don't become anxious. They're prepared for a longer wait, and they do not transfer that anxiety to us, to the team, etc. I think that is where it is going wrong, and we are ending up with higher cesarean for failed induction. I just wanted to put this point that there is a slight change in understanding about failed induction. I wanted to put this point. Yeah.
Thank you, Shobha, for your
Yeah.
inputs. So, but still, I would like to continue that failed induction has become 41.3% in her case. So, when we are doing induction of labor for the low risk patient, we have to be little careful. Secondly, as Dr. Sumitra said, and Dr. Pailios also said, it is a program labor when we are doing for the low risk patient. I have come across one study where, in 2001, their cesarean section rate was that private cesarean section rate in a private, clinic was almost 71%. And the person obstetrician realized why my cesarean section rate is very high. So they tried to analyze. They did the auditing, and they did a different courses. Still, the C-section rate was not coming down. Ultimately, they started doing group practice. And in group practice, whenever patient goes in labor, somebody is there, some senior person is there. And they were not admitting the patient till patient was in active labor, that is more than 4 centimeter. So that made more vaginal delivery to happen and less cesarean to happen without affecting maternal and fetal outcome. So program labor is one solution. And second solution, you can always have a group practice of your choice of colleagues or obstetrician, and patient can go in labor every time some senior person is there to look after. That's what I've come across this study, and I was very much impressed by that study. So I don't have to say much, but now, anybody wants to comment, please comment. And otherwise, Sunil can, end with the webinar. And I must thank all of you giving your input, especially Paili sir, Sunawala sir, Kamal Bakshi sir, Sumitra, then Pesi and our Vidya and Shobha. Dr. Sudesh also, gave a very good inputs, and I'm really thankful that I want all of you to join on 3rd Wednesday of the month between 4 to 6 p.m. You can spread this news to all your friends, colleagues, and juniors and seniors that these are such a highly scientific session we are conducting. So at least you can spread the message to all of
Sure,
them.
ma'am. Sure, that's a nice thing. Definitely will do.
Yeah, thank you, Madhuri madam.
Thank
Dr.
you,
Atul,
ma'am.
it was a great presentation, and we had a good discussion and critical appraisal. Just one note from my side, as it will promote the juniors and PG students to have a research-oriented mindset and conduct such studies. So this was observational study. If at all consultants are practicing to wait up till 40 weeks, or even following that up till 41 weeks, as RCOG guidelines say, or having stripping of the membranes like that. So if we have a comparative study, that would be good. The original US trial that was this was a multicentric trial. Arrive trial was multicentric, and it was in US. So it was in 2018, and immediately after that, probably you had US study in 2019 to check those principles in our setup. But as all seniors have mentioned here regarding the nitty-gritties of the induction of labor methods, the definition of a failed induction, so you should consider this now for a refined and further studies. And our seniors should guide the juniors regarding comparative trials and RCTs, so that our very own Indian studies can contribute to review and meta-analysis, systematic reviews and meta-analysis, so that it is going to help ultimately to the clinical practice and disseminate the evidence. Okay, so it was a very good session today with thoughtful discussions and inputs from stalwarts. Here we come at the end of 10th episode of our Clinical Pulse of JOGI presentations. I'm going to give thanks, giving notes to each and everyone who contributed for this presentation. First and foremost, I thank Dr. Jaideep Tangsang, President FOGSI, and our very own Madhuri Patel, Madam Editor-in-Chief, for such a wonderful session. Today's guest of honor, Dr. Kamal Bakshi Madam and Dr. R.P. Sunawala Sir. Chairpersons, Dr. Fesi Louis, Dr. Vidya Thobi, and Dr. Sumitra Yadav Madam. And our speakers, Dr. Paili Sir and Dr. Atulya. Dr. Pradnya Changede and Dr. Supe, who are my seniors and doing a lot to make such wonderful programs happen. And our office team, Miss Maria and Miss Arti, for having such a wonderful program come into reality. Thank you, Madhuri Madam, once again, and thank you each everyone and all the delegates who attended the programs and students. Without you, it is not possible, and we need input from you, and we want you to promote our activities all over India and even abroad. Thank you very much.
Thank you, thank you. I have a special thanks to my editorial team, editorial manager Sunil and both Pragna. They are always there. And of course, our Maria in the office and the Aarti, they are doing lots of work to do all the clinical pulse becomes the successful. So thank you everybody for joining. And I
Thank
hope
you.
Thank you, madam. Thank you, madam.
Yes, thank you.
Thank you.
Thank you.
Thank you very much,
Very
ma'am.
much.
Thank you, Paili sir.
Can I end? Thank you, everybody. Can I end this meeting for all?
Yes, yes, yes.
Thank you.